Skin cancer risk is not one score and not one trait. It is a pattern built from pigment biology, ultraviolet exposure, personal and family history, mole burden, and immune health.
You know, when we talk about these risk factors, we're really looking at crucial population context. This isn't about handing you a definitive personal diagnosis, and it's certainly not about mapping out your inescapable destiny.
Wait, hold on a second. If it's just population context, then how do I actually know my own personal risk?
Well, before we break that down, we need to establish exactly where this information is coming from. This explainer was written and edited by Dr. Thomas Hawker, a triple board-certified Harvard and Mayo Clinic-trained dermatologist, Mohs surgeon, and dermatopathologist. Now let's look at how that pattern actually comes together.
Section 1. Pigment and ultraviolet. Understanding the skin's response to UV light.
Okay, so to understand how easily ultraviolet light injures your skin, and yes, that includes the sun or an indoor tanning bed, we have to look at the damage itself. UV energy literally damages your DNA directly, and it creates these highly reactive molecules that injure cells indirectly. A sunburn? That's just your skin's visible alarm bell going off, telling you an exposure completely overwhelmed its defenses. And indoor tanning absolutely belongs in this exact same conversation, because radiation is still UV radiation. Now, to measure this sensitivity, dermatologists often look at what's called the Fitzpatrick skin phototype. It's a traditional scale describing how skin tends to react to UV exposure, and it's built around two really practical questions. How easily do you burn, and how readily do you tan? Type I usually burns very easily and doesn't tan at all, which signals high UV sensitivity. Way on the other end, type V6 very rarely burns and is deeply pigmented.
Right, but just to clarify something here, isn't the Fitzpatrick scale basically just a medical label for race or exact skin color?
No, actually, that is a super common misunderstanding. The Fitzpatrick type measures a reported, highly subjective reaction to the sun, a burn-tan response. It's not a race category, it doesn't measure ancestry, and it is definitely not a perfectly objective measurement of skin color. Skin cancer occurs in literally every skin tone. Confusing this scale with race or visible skin tone can actually create a really dangerous false reassurance for patients.
So let's look at hair color as a visible clue to your pigment biology, specifically involving a receptor called MC1R. More active signaling here favors eumelanin. That's a brown-black pigment, and it absorbs and disperses ultraviolet energy incredibly effectively. But red hair-associated MC1R variants often shift that production over toward pheomelanin, which is a red-yellow pigment. Not only does pheomelanin provide far less UV shielding, but its chemistry can actually promote oxidative stress. This means those reactive molecules we talked about can consume cellular antioxidants and damage the actual components of your cells.
Okay, so does having red hair mean you are just absolutely guaranteed to get melanoma?
No way, absolutely not. Red hair is just a really useful signpost for an inherited pigment pathway. It's a clue, it's not a guarantee. People without red hair can still carry MC1R variants, and UV protection matters immensely for everyone. The best way to think about it? Pigment is a protection system, not just a paint swatch.
Moving on to Section 2, Moles, History, and Immunity. Clues to susceptibility and immune guardrails.
Now, before we even look at immunity, we have to look for clues that a susceptible environment already exists. Having a lot of common or atypical moles, or history of actinic keratoses and previous skin cancers, these are massive clues that the necessary biology and exposures have already produced disease once. But beyond just past sun damage, we have to look really closely at your immune health. Your immune system acts like a guard, helping to recognize and restrain abnormal cells. When diseases or treatments weaken that surveillance, the entire risk profile shifts. We look closely at specific settings like solid organ transplants, CLL or lymphoma, HIV, allogeneic stem cell transplants, and chronic systemic immune suppression.
But why do those specific immune conditions matter so much? Like, does it really change the risk that significantly?
Oh, it changes it dramatically. To give you an idea of the scale here, in one U.S. cohort, solid organ transplant recipients had a much higher incidence of cutaneous squamous cell carcinoma, or CSSC, compared to controls. The hazard ratios varied by the transplanted organ, from 6.53 all the way to 14.83. And in another cohort in Denmark, HIV patients showed an incidence rate ratio of 5.40 for CSSC. This proves that your immune history dramatically shifts population risk, and it requires clinician-guided prevention. And just as a quick aside, you should absolutely never alter an immune medicine on your own just because of something you read on a web tool. Okay, let's reset for a second. We've talked about pigment, UV damage, moles, prior cancers, and immune health. But if all of these factors matter, why is it that different online risk tools give me completely different answers when I type in the exact same information?
That is a major frustration for patients, and honestly, a fantastic question. The answer comes down to exactly how these tools are built behind the scenes. Take the QSkin Melanoma Risk Calculator, for example. It's built on a cohort of 41,954 adults, ages 40 to 69 in Queensland, Australia, and they were followed over a few years. Now, it's a highly validated tool, but for that specific population. Validation simply tests whether a model performs well in people who weren't used to build it. It's crucial to understand that performance in an Australian population does not guarantee performance in a totally different population across the world.
When you look at them side by side, you can see exactly why these public tools spit out totally different numbers. They differ fundamentally in cancer type, target population, the actual outcome, the time horizon, and the output format. For instance, the U.S. Melanoma Risk Assessment Tool outputs a 5-year absolute risk, but it's completely restricted to eligible non-Hispanic white adults in the continental U.S. Meanwhile, the first primary melanoma tool offers 10-year and lifetime estimates, but its cohort performance is highly population-dependent. Because these tools measure totally different things in different groups of people over different time frames, their scores are absolutely not interchangeable.
Because of these persistent limitations, SkinTrust took a totally different path. Rather than attempting to calculate a personal risk percentage, which, as we just saw, can be deeply flawed outside of specific populations, SkinTrust built an educational profile of evidence domains. It used AI-assisted literature synthesis combined with expert clinician judgment to group related factors. So, if you report easy burning, freckles, red hair, and light eyes, the SkinTrust profile recognizes those clues as describing one connected pigment domain. It doesn't artificially count them as 4 independent, isolated causes. And by the way, the AI assistance here is just a process disclosure for how the literature was synthesized and how edge cases were tested. It is not a claim of prospective validation. The model remains strictly educational and unvalidated.
Okay, but what if I take a profile like this and it actually gives me a score of 0? Does that mean I'm totally in the clear?
I am so glad you asked that because this is a critical boundary we have to draw. A 0 domain count means only that no listed eligible factor activated a domain. That's it. It never means 0 or low personal risk. It absolutely cannot rule out skin cancer. And if the tool doesn't have enough evidence for your specific skin type, it will show an evidence-limited state. It is designed so it will never provide false reassurance.
Section 3. The ultimate override. When symptoms beat the profile. Now, let's pivot to the absolute most important rule of this entire explainer. When does a profile completely stop mattering? The answer is physical clinical reality, symptom concern. A changing, bleeding, painful, or non-healing spot overrides any educational profile, and it overrides any domain count or mathematical model, no matter what a web tool says. An online profile cannot diagnose a lesion. If you have a warning sign, it requires immediate clinical evaluation, period.
Section 4. Next steps and prevention. Turning risk factors into an action plan.
Let's turn all of this evidence into a concrete action plan. Here are the neutral, actionable next steps you should take. First, do not use an online profile to judge a single spot. Second, before your next visit, write down your previous skin cancers, serious sunburns, indoor tanning exposures, immune conditions, and any first-degree family history. Third, bring this full pattern to a dermatologist. Bring the whole pattern, not just a single number from a website. And fourth, ask for a personalized prevention plan to reduce avoidable UV exposure.
So the core idea here is to use this knowledge as a conversation aid with your clinician, rather than trying to figure out your own screening schedule at home.
Exactly right. Screening intervals depend entirely on your full history and a physical examination. A web profile simply cannot prescribe one for you, but it can help you organize your questions so you and your doctor can make the best decisions together.
I invite you to read the complete article at skintrust.com to fully understand these domains and, most importantly, to discuss your individual decisions with your treating clinician. As the mission statement notes, Dr. Hawker created SkinTrust to provide free, evidence-based dermatology education and help patients and clinicians make clearer decisions together. But here is a final question to leave you with. If your immune history can change your risk this dramatically, what else in your medical file is silently altering your skin's defenses? Join us in our next explainer as we answer the question, what does a high-risk mole actually look like? Thank you for learning with us.